Did we go?
Yeah.
Okay, so this presentation is about the National Patient Safety Goal on using alarms safely. Okay, so more about this goal is we are improving the safety of clinical alarm systems, which is to make improvements and ensure that alarms on medical equipment are heard and responded to on time, and to increase staff awareness of alarm fatigue and the implementations to manage it. Okay, so this slide is about the importance of the goal and how a change might improve patient outcomes. So alarms aren't meant to alert caregivers of potential patient problems. If they are not properly managed, they can compromise patient safety. So there are numerous alarm signals, and the resulting noise may tend to desensitize staff, which can lead to missed or ignored alarm signals, or staff and the patient family members may actually disable the alarms. One of the biggest issues on this can be alarm fatigue, and that is the desensitization, if that's a word, to staff. And here I just listed the Joint Commission's elements of the performance. There's a bunch. I don't know if you want me to read through them, but we'll touch on these in the later slides on some articles that I looked up. Okay, so here's a case scenario to kind of put it into play. So this one is a 36-year-old female receives hemodialysis through a right forearm AV fistula. The nurses working in the dialysis unit are busy administering medications and preparing for the next shift of patients. Machine alarms have been sounding intermittently on various patients throughout the shift. The patient's venous pressure alarm is triggered, and a nurse promptly resets the alarm and returns to her previous task. The venous pressure alarm continues to go off, with nurses resetting the alarm 3 separate times. The 4th time, the alarm sounds and the nurse responds. The patient complains of pain in her right arm. The nurse then discovers that severe edema in the right forearm from an infiltration. So, do you think alarm fatigue contributed to compromising the safety of this patient? Case scenario 2 is one that I actually wrote from personal experience. So we have a patient on the acquired brain injury unit is alert and oriented ×2. The patient is on mechanical ventilation and is frustrated about his situation. He uses his call light for staff assistance, and if he is not attended to after 1 minute, he purposely coughs until his ventilator alarms. He can do this 10 times a shift. How do you think that this should be managed? And what effects do you think this will have on staff? So we can answer that later. So here's just some alarming information. The data is actually from 2011, 2012, but it's still pretty shocking. Especially this one. Alarms, 942 alarms sound each day in a typical 15-bed unit. And then that's a shame, 90% are unanswered.
Oh my gosh.
So more things that we'll talk on. We have locate the source of each alarm. We need to limit active alarms based on patient needs and set volumes accordingly. So this first article, called Alarm Fatigue and Patient Safety, we have false or nuisance alarms when the alarm thresholds are set too tight or triggered inappropriately is the cause of alarm fatigue, or the primary cause of it. So this would be, so the false or nuisance alarm is basically crying wolf. If it keeps going off and there are no problems, people are not going to think that it's an emergency when it actually is. So we have 81% of nurses in this article said that nuisance alarms reduced trust in alarms and hindered patient safety. So maybe the default alarm settings were not appropriate for all patients. The implementations that the nurses decided upon in this article were to individualize the alarm thresholds to limits that are clinically appropriate for individual patients, creating protocols for alarm settings and training staff on how to use them, And when an alarm occurs, prompt response in correcting the cause may decrease the number of alarms the nurses are exposed to. So touching a little more on these. So individualizing the alarm thresholds. This would be a wonderful thing to do for the patient in case scenario 2. Individualizing the vent alarm so that it wasn't going off every time he purposely did a couple coughs to get the attention. Maybe you would set the alarm off when there is an actual emergency. So it is important for staff to know how to do this so that you're not disarming something on the ventilator that could really cause some patient damage. And then correcting the cause of the alarm for the first time that you go in there. So if you think that the lead might be falling off, anything that you think could help, go ahead and try to do it while you're in there, because it will help you in the future and make sure the alarm doesn't keep going on. On the next article, Assessment of Clinical Alarms Influencing Nurses' Perception of Alarm Fatigue. There were 26 nurses assessed in the article, and 26 out of 26 believed that there should be different alarm noises for the level of severity on the devices. So, since we're not really the ones that make the machines, that's not something that we can really control, but if we could send letters to the people that make them, that would be great. But we can focus on the things that we actually can do, and that's what we'll mention on this side. And a recurring theme is that the nurses felt that nuisance alarms decrease their trust in the actual alarms that are going off. So, the nurses in this article concluded that a central staffed alarm management system and communication device increased alarm communication to nurses. Adjusting alarm parameters, having every staff member know how the alarms work and what the critical alarms are, and then additional training for staff to understand how the monitors work and how to set the parameters to each specific patient. And this is touching base on it a little more. So the management system in the ICU, which I've seen, is they have all the monitors set up in the front and there's one person watching them all. And in my hospital, these are the people that call you when the telemetry is going off, and they're also monitoring the people actually in the ICU as well as out of the department. And then adjusting the alarm parameters seems to be a trend in these two articles. So just making sure that each alarm is different for each patient. Say you have a patient down the hallway who's more critical and you can barely hear their alarm, you want to be able to turn up the volume so that if something was happening, you can actually hear it. And then the additional training for staff. In the next article, this one actually touched on how many alarms are going off in 40 hours. So this was a coronary care unit with 88 patients, and they assessed for 40 hours on days and nights. There were 61 patients on ventilators and 39 on hemodynamic support. For the parametric monitors, in 40 hours, there were 227 alarms, which is about 5.7 alarms per hour. Other alarms, which were the infusion pumps, dialysis, and ventilators, were 199 alarms in 40 hours, or 4.9 alarms per hour. As you can see, that would be driving everyone crazy, and obviously that could contribute to some alarm fatigue. So their first step in preventing alarm fatigue is to properly place the electrodes, cables, and sensors. It's safer for the patient, and you won't get those false alarms saying that there's a problem when there isn't one. Next, staff should be able to program and configure the equipment systems and adjust the sensitivity and volume. So this is just like the other two articles, being able to individualize the alarms per patient. And this is touching on those implementations. And just a quote I got from the article. Resolving the causes of alarms demand time from staff, cause distractions during nursing care, and may lead to errors due to lack of concentration. And that makes a lot of sense. If you don't want to keep getting called while you're trying to give a med and accidentally do something wrong because you're frustrated about all the alarms that are going off. Alright, so here are the recurring themes that I've grasped from all the articles. So, first, do what you can and do it right the first time. Properly place the monitor leads. If alarm is going off, you need to get there as soon as you can and correct the reason while you're in the room, or as soon as you can. Utilize staff members. So be able to use all staff members that can go in and at least assess the patient on why the alarm is going off, so that the nurse doesn't have to drop what she's doing or rush through something to go and assess it. Education on the machines and the alarm meanings. So knowing what each alarm sound means, so that if there's a critical alarm, you can run to that one and skip the one that's saying IV occluded. And then a central staffed alarm management system. And this is the one that from the example with the ICU, where they had someone monitoring it all and can actually tell the nurse if there's a real problem happening. Individualize alarms for each patient needs, and then educating the staff on how to alter the alarms per patient, or at least having the appropriate staff be able to do it, like a respiratory therapist would monitor or reset the ventilator alarm setting, because I would not be comfortable touching all the buttons on there. And that is it. Do you have any questions?
No, that was very informative.